Hello everyone, my name is Stuart Pope and I'm the current PGY2 in critical care at Emory University Hospital, and today I will be discussing the safety of lactulose in decompensated cirrhotic patients. Neither I nor my co-investigators have anything to disclose for this research. I wanted to begin by reviewing some numbers to help orient us to the scope of liver disease and liver failure in the United States. Chronic liver disease affects more than 4.5 million adults in the US and has consistently been in the top 15 leading causes of death, coming in at number 11 according to the most recent statistics. So there is a high likelihood that you will encounter patients with chronic liver disease in your own clinical practice. There's a subset of chronic liver disease patients who will experience decompensation, which is defined as the development of ascites, variceal hemorrhage, or hepatic encephalopathy. Decompensated cirrhosis is associated with poor prognosis and a 5-year mortality rate that approaches 50%. More recently, a newer classification of liver failure has been developed for a subset of patients with decompensated cirrhosis, termed acute on chronic liver failure, defined by the presence of those decompensation symptoms, but also the presence of extrahepatic organ failure. And ACLF has gained clinical research in recent years due to the high 28-day mortality rate, which ranges from 23 to 74%, depending on how severely ill the patient is when they present or how many organs are in failure. Hepatic encephalopathy is a common complication of cirrhosis and is characterized by a wide range of neurological abnormalities, ranging from confusion and lethargy all the way to coma. Treatment has historically been aimed at lowering serum ammonia levels. However, it has been well demonstrated that cirrhotics have an acquired tolerance to high ammonia. So treatment of HE should really be focused on symptom management rather than targeting specific levels. There are several medications commonly used to treat hepatic encephalopathy listed here for your reference. And guidelines currently recommend lactulose as the first-line agent for overt or symptomatic HE. However, there are a couple limitations to this recommendation. One being is that there is limited data to support lactulose use in the decompensated or acute on chronic liver failure patient. And there are serious risks of lactulose that must be considered, especially in critically ill patients. Therefore, the purpose of this project is to assess the safety of lactulose for the treatment of hepatic encephalopathy in cirrhotic patients who present to an ICU with decompensated or acute and chronic liver failure. This study was an IRB retrospective chart review from November 2017 to October 2020, which took place in the surgical and transplant ICU at Emory University Hospital. Patients were included if they were adults admitted to the surgical or transplant ICU who presented with decompensated cirrhosis and were treated medically for their hepatic encephalopathy. The only exclusion criteria in our study was prior liver transplantation. The statistical analysis used is listed here for your reference. A p-value of less than 0.05 was considered significant. For the primary outcome, we decided to choose a composite outcome of gastrointestinal complications, including ileus and bowel perforation. Based on additional safety concerns of lactulose use in critical illness, we examined metabolic disturbances, which was defined as a pH less than 7.3 or a bicarb less than 18. Uncontrolled diarrhea, which was defined as greater than 5 bowel movements per day or greater than 1,000 mLs per day of stool output. And we also looked at ICU and hospital length of stay. After chart review, a total of 274 patients were eligible for inclusion. 35 patients were subsequently excluded due to prior liver transplant history. Of the remaining 239 patients, 155 of those patients received a lactulose-containing regimen, while 84 patients received non-lactulose-containing regimens for the treatment of their HE. Looking at the baseline characteristics, patients were typically white men with median age of 55 who were admitted with criteria that met the definition for ACLF and had alcoholic cirrhosis as their underlying etiology. There were no statistical differences identified for these characteristics. Additionally, patients had high MELD scores on admission and moderate SOFA scores, which were not statistically different between groups. However, patients in the non-lactulose group were significantly more likely to receive fewer medications for their hepatic encephalopathy treatment than patients in the lactulose group. The primary outcome was statistically significant between groups, with a higher number of events occurring in the lactulose versus the non-lactulose groups, and this was primarily driven by the incidence of ileus formation. For secondary outcomes, metabolic disturbances were statistically more common in the non-lactulose group, whereas uncontrolled diarrhea was more common in the lactulose group. There was no difference in length of stay or in hospital mortality between these two groups. As previously discussed, the use of lactulose for the treatment of hepatic encephalopathy in patients with decompensated cirrhosis remains understudied. Our results indicate that lactulose is associated with a higher incidence of GI complications, particularly ileus. Despite these differences in complications of lactulose, however, patient-centered outcomes such as length of stay and mortality were similar between groups. There were a few notable limitations to this study. It was a retrospective study design. There did appear to be a clinician prescribing bias in which providers were less likely to order lactulose for patients who they deemed more clinically unstable, which biased which patients received which type of medication for their HE treatment. However, we do acknowledge that this prescribing bias was not necessarily captured in our severity of illness scores as outlined in our MELD and SOFA. And finally, the data collection of this study only focused on ICU admission, so it is possible we did not capture additional hepatic encephalopathy medications administered prior to ICU admission, which may have influenced the treatment group selection or outcomes. Overall, our study indicates that lactulose is associated with a higher incidence of GI complications in patients with decompensated cirrhosis. This data may influence practice changes in our own surgical ICU, but ultimately prospective randomized trials are warranted to investigate the safety concerns of lactulose in critically ill patients admitted with decompensated cirrhosis. I would like to thank my co-investigators for their work and contributions on this project. Here is my presentation objective, followed by assessment question and answer for your reference. Please feel free to email me any follow-up questions at the email address located at the bottom of the slide. I look forward to the Q&A session and discussion next Thursday on the 29th, and I appreciate your time today. Thank you.